Hello, everyone. Welcome. I'm Frances Padilla. I'm president of Universal Healthcare Foundation of Connecticut, and I am happy to welcome you to one of an occasional series of conversations that the foundation is hosting. This one is racism and COVID-19. Racism and healthcare, what COVID-19 has exposed. I want to thank the Connecticut Health Foundation, the Graustein Memorial Fund, and the Donahue Foundation, our friends and colleagues who have co-sponsored this event with us. We're going to begin, we began hosting a series of conversations last month related to our priorities, and one of which is advocating for populations that are particularly affected and disproportionately affected by the COVID-19 health crisis. And in the fact that in the midst of all of this, we also have come on this national crisis, the lynching murder of George Floyd and Ahmaud Arbery and Breonna Taylor, among the many people who have died at the hands of racism. And of course, the national uprising that has occurred has made us all really stop and take stock and think about how this insidious problem that we live with in our country, and that particularly Black people live with in our country, is at the root and the heart of so much of the problems that we have in our country. So this uprising, this made the conversation even more timely and even more critical. What I'd like to do is take a moment of silence. Actually, before I introduce my guest today, I want to ask that we all observe a moment of silence for George Floyd, Ahmaud Arbery, Breonna Taylor, and all those who've lost their lives to racism. Thank you. So I'm going to introduce our guests today. My guests today are three good friends with whom I've had the pleasure of working at various points and for a very long time. We have, in the order that they're appearing on my screen, we have Denise Smith. Denise is the founding executive director of the National Association of Community Health Workers, and she is herself a community health worker. Denise has 15 years experience advancing equity, diversity, and inclusion in healthcare delivery, prevention programs, and partnerships. She is a Robert Wood Johnson Culture of Health Fellow and a Universal Healthcare Foundation Leader in Action. To my right is Asher Delerme, a long old friend of the family. Asher is the executive director and the clinical supervisor of the Chemical Abuse Services Agency, CASA, in Connecticut, in Bridgeport and New Haven. He is a strong advocate for multicultural health. He developed the Arredo Apartments in Bridgeport, which is a supportive housing program for homeless individuals. And he originated a Caribbean-based music therapy program entitled Rhythms in Recovery. Asher is also a professional musician. And then to my lower left is Dr. Julian Nieves. Dr. Nieves is a practicing physician and faculty member at the UConn Health Center. He works in primary care innovation, health promotion, and community engagement, among the many other areas that he has excelled in. He's a passionate health equity advocate with a master's in public health. And I'm proud to say also a former member of the board of Universal Healthcare Foundation of Connecticut. So welcome, Denise, Asher, and Julian. I am very happy to have you here. But we're going to have a conversation for about a half hour. And I want our participants, our audience, to know that there's going to be plenty of opportunity for questions, because we really want to know what you are thinking. We are all feeling very raw, and I think that we have to acknowledge that. And so I want to make sure that we hear your questions and your comments. Please use the chat function and write your question. Rose Ferraro, who is a member of our staff, she's a program and policy officer at the foundation, is going to be taking the questions and reading them to us, and then we'll go from there. So I want to start our conversation with a quote from one of a young Black man with whom we've been working. We have a program where we're talking to people who are working in advocacy in other issue areas outside of healthcare about how we, the foundation, could do a better job at engaging people of color in advocating for change in healthcare. And the work we've been doing together has been happening over the course of the pandemic. And of course now with the current situation. And he said, racism is a public health pandemic. He said that about a month ago. Would each of you reflect on what this statement means to you from your experience and your perspective? I'd like to start with Denise, and maybe Denise, you can also put it in a historical context for us.
Thank you, Frances. Good afternoon, everyone. Let me start by saying that my prayers are with you and your family and your communities during this time. I scanned the chat quickly and I saw many allies and friends, mentors and comrades. So I just want to acknowledge all of those who are on the call, who have worked with me, have mentored me, have shared in this legacy of advocacy. You know, what it says to me is that this story, this narrative, this reality has been passed down from generation to generation for hundreds of years, certainly here in what we call the United States. For young men to be able to so clearly and simply articulate racism as the core, as the groundwater, right? As the upstream issue, as the litmus test of our time, lets us know that we can begin at the end. If we do not deal with this scourge of racism, we will not chip away at our individual missions in our various organizations around equity and social justice. So let's just start there at the end, that he has put that before us. Connecticut is an interesting place. I've been in and out of this state my whole life. And I am connected here because I grew up behind the Mashantucket Pequot Native Preserve down in Connecticut. I acknowledge that we are on sacred land and stolen land. So we have to go all the way back and remember that for generations, people have lamented the fact that they look at land that was honored. They look at land that was treasured, and really it is now lost to them, that lives and stories are lost. Connecticut has an interesting history in terms of the initial colonies in this country. Connecticut was late to the game of abolition. They had a mindset of gradual abolition. And as late as 1784, Connecticut said, well, if you're born after 1784, you still have to be a slave, but at least you know that freedom comes at age 25. And that was as late as 1784. We have a history that is so embedded itself into the fabric of every system that we look at those indicators of income and housing and educational attainment, incarceration rates, criminal activity in our communities, environmental pollution, and various health outcome disparities. And we see the thread of the lack of access, the lack of dignity, the lack of our humanity being acknowledged. We were property. Indigenous Americans were property. Africans were property. And so we have this as our legacy. We are still in that place. And so the fights that we wage through systems and through policy, it is that feeling of a step forward, two steps back, because we know that hearts and minds, we know that transference of racist concepts and beliefs and motives are underlying current. And even as to center community voice policy systems, we wrestle with this unseen enemy that continues to rear its head. And it sobers us to our work. There are national examples, many reports that many of us are aware of. I think about the signature report of W.E.B. Du Bois, that sociologist, who brought to us his Philadelphia study, who at that time in the late 1800s was saying, you know what? I'm seeing a lot of social needs and poor health outcomes, and I'm pointing back to poverty, ignorance, what he called the dislike of the stranger, when he looked at the lack of progress and the concentration of poor health outcomes and poor health status among African Americans who had migrated from the South to the North. We can look at Margaret Heckler's report that ushered in the Office of Minority Health, that a beacon for many of us, as centering some sense of a drive toward disparity. When Margaret Heckler issued that report, she said that this report wasn't supposed to be something that sat on a bookshelf. She literally said that it should generate an accelerated national assault on health disparity. But we have not taken up that charge in all of these decades. And just as
we have not.
May 27th, 2020, there was a hearing that Chairman Neal had about COVID-19 and communities of color. This was May 27th, just last week. And he said in his opening statement that COVID-19 has shown a light on our country's centuries-old legacy of inequality. So that thread from the origins of this country until now is the thread of racism and the way that racism is embedded and drives systems and policies.
So Denise, you're breaking up a little bit at my end, at least. I'm going to ask you to come back to this. And I'd like to actually, you said something about Connecticut being late to the game. And, a lot of us feel like Connecticut doesn't want to lead, but also doesn't want to be too far behind. And what we do is we work around the edges of these issues. So health equity has been on the radar, but we have been working with insufficient sense of urgency. I want to take this for everyone. I know that there are people who are participating today who live this reality. I know that there are others that do not, for whom maybe even the last week has been a surprise or some new awakening. I'd like to take it over to Asher and ask Asher to talk about this in terms of what it means to real people, what it means to the people who have HIV and who are homeless and who are in recovery and who have been incarcerated that you work with. and the staff that you have who are essential workers, who are also people of color. What can you share with us on the ground, real life experience that highlights what Denise has just laid out so well?
Well, first of all, thank you, Francis, and thank you, Denise. I heard you loud and clear, by the way. You didn't break up on my end, and your message was very well taken. First of all, I just want to say that our organization, CASA, was set up, in fact, to deal with some of these inequities that we're talking about 30 years ago, by the way. And it was designed to specifically work with inner city communities, women, African Americans, and Latinos to really provide a space and services that are meet the particular needs of that community. But what we found over time, or at least what I found over time, is that those inequities continue to exist. Because yes, they're very systematic, they're very structural, and they're very difficult to change. And what I've seen on a ground level is that even though we have a program, for instance, where we provide residential services to HIV/AIDS population, people who, by the way, are probably at one of the most marginal places in our society. You're talking about folks with underlying medical conditions, folks who have been pretty much ostracized by the rest of society, individuals who have comorbid issues on top of the medical issues. So what I found is that, while we've set up a program that you have case management, you have medical case management, you have connections to behavioral health services, you have connections to primary care services. All of those things are great. All of those things are good. But in a time of a crisis, of a medical crisis like COVID, what we found was that we were still experiencing the barriers that the system, that the structure of the system, the inequities that have always been there. We were still experiencing those issues, and they were getting in the way of providing good services for the folks that we service. And the example that I can give you is that basically at some point during this epidemic, we started to develop a cluster of COVID positive individuals at one of our residential sites, the HIV/AIDS residence program. And obviously I kept the third eye open for those individuals, because I knew that if anybody was going to be vulnerable to this, it would be that population. And lo and behold, it was. So we thought we had some systems in place that could adequately respond to the needs that existed. But the reality was that at a certain point, people were starting to get sick, people were symptomatic, and we had a very difficult time getting them medical services, because the system was set up in such a way that it was telling people, I guess at that time, the protocol was, well, you stay home, you drink your teas, you do what you have to do, but we're not, in fact, some folks were not even getting tested. Some folks were not even getting medical care. And we had to basically insist that these individuals be seen and be treated. Ultimately, I had to get involved because case managers called me and said, listen, we're not getting anywhere. And the other issue for us is that this is a congregate living facility. So it didn't really bode well to have individuals who are getting infected living together in such close quarters. So ultimately, I intervened and communicated with the medical provider at one of the community healthcare centers, who happened to be a friend of mine, who I knew. And he distinctly said to me, Asher, unless you're rich or you're a politician, you're not going to get tested. And so for me, those two words have a huge connotations in terms of the inequities that we talk about in our system of healthcare. Rich means you have money, you have worth, you have value. So does that mean that our clients don't have, obviously they don't have money, they were not valued, and they have no worth in the system's eyes. In terms of being a politician, that connotes to me that you have to have influence, you have to have power, and you have to have some kind of status. And right there, for me, that's the definition of healthcare disparities that we're talking about. Ultimately, because I got involved and other people got involved, I called local officials, I called legislators, I called the CEOs of the community healthcare center, and eventually things did start to change. And I'm not saying it was because of me. I believe that I joined a chorus of people that were calling for change. And ultimately, things did start to change in such a way that we were able to get folks tested. We were able to get folks hospitalized. We were able to get these intermediary housing services for people who are leaving the hospital and going into some other form of housing before they came back to our facility. So ultimately, things did start to work out, but my fear, my concern, and it was not lost on me that here we were, a system, a provider with social supports, medical supports, professional supports, and we were able to raise our voices and do something. But what happens to the community at large? Those individuals, like the individuals that we serve, that perhaps don't have that kind of social professional support to work with them.
And without the advocacy that you provided, right, they would not have had a voice. And their humanity, which is part of what Denise lifts up, was simply not enough to get them what they needed. And of course, this is one example of many breakdowns in the system that are really rooted in structural racism. And, you know, we have to use that word. We have to say that that's what it is. We have to call it that, because we as a country dance around that. We use other terms. It is racist, institutionalized racism that has created these disparities. And we work within them. Here we are, all people of color, the four of us, working to try to change the system from within, and also to create what I would call workarounds in the meantime to help people get their immediate needs dealt with. So I just want to shift for a moment and then open for some questions to Julian. So Julian, you are a practicing doctor. You've been a doctor for 20 years, a lot of that time here in Connecticut, and I know also in Boston. You are a community doc. Right now you're associated with UConn Health Center. You have actually been working on a floor dedicated to COVID-19 patients. Talk to us, tell us about what you see as a physician caring for people and how you have experienced the health system as a physician of color and how you see your patients experience it.
Thank you, Francis. I really appreciate you having me join this discussion. I appreciate all your work. And Denise and Asher, thank you for your contributions. I really appreciate the historical context, and it's very poignant. Public health is a political, sociological, economical, and sociological issue. You can't separate public health and healthcare from what's going on in society. They're not, you can't silo it. And that's part of the problem, is the fragmentation of healthcare. going back to 2002 with the landmark article, Unequal Treatment, from the Institute of Medicine that identified racial health disparities. And back then, the issue of implicit bias, institutionalized racism, socioeconomic determinants of health. Back then, this was brought to the forefront. And I'm sorry to say, but over the past 20 years, I don't know how much progress we have made really to say that we are where we need to be. I think there's still a lot to do. From my perspective as a community physician and working in the hospital, I think the healthcare institution, as fragile as it is already, was hit pretty hard, and we weren't prepared. Public health system wasn't prepared. Institutions were not prepared, and it hit us pretty hard. So there was a lot of disorganization. There was a lot of chaos. Some states, some institutions handled it better than others. I think that what this crisis did was to exacerbate some of the underlying issues and inequities that already existed when it comes to, for instance, language barriers, access to health, and now in terms of digital medicine and telemedicine, access to digital connectivity and telemedicine, and transportation issues. All that has come into play. And when we talk about implicit bias, implicit bias is basically, the bias and the prejudice that we have subconsciously at the institutional level that we all have. Even, we all have implicit bias. We all have subconscious biases. And if you ask, a healthcare professional or physician, do you treat, brown people or Black people differently than you do any other patient? And obviously they'll say no, but there is implicit or subconscious levels of biases, just basically, just based on the society that we've been brought up. So there's that, and then there's the continued fragmentation of care and access to care that's become an issue. In the clinical setting, we have quality assurance measures, we have quality protocols that mitigate any variations in the delivery of healthcare. In crises, those quality metrics and quality protocols are challenged and tested. And what happens is that, again, when those guardrails to provide quality healthcare are tested, there might be, again, some exacerbation of underlying biases and institutional disparities that are brought to the forefront. And some examples are, for instance, patients not getting timely care as they should, or patients perhaps not having access to a provider in a timely manner. These types of issues become a little bit more prevalent when you're dealing with a crisis, and they've been there all along, but it just becomes exacerbated when you have a crisis like COVID-19.
So you told us a story about a patient that came into the emergency room who was COVID positive, who was having a heart attack. Can you share that story and how that isn't it's a real life example of this issue of the protocols breaking down?
Well, yeah. So, in the hospital, we're setting up, protocols and screening patients as they come in. And, it's not the first time, but, there's been situations, and there was one particular case, this case that you mentioned, where there was a patient who was being ruled out for COVID. unfortunately, COVID-19 can present as cardiac symptoms as well. It's still early, and we're still trying to figure out all of the different ways that COVID affects the human body. And so this patient was having evidence for what we'll just break it down to as a heart attack. And per protocol, you immediately need to get a catheterization. You immediately need to go to the cardiac suite and get a cardiac cath. That's protocol. And as a matter of fact, it's standard of care in many hospitals are actually that's one of the quality measures that hospitals have to abide by and are graded by. In this particular case, things were delayed because he was possibly COVID-19, and he was being ruled out for COVID. And so again, it was early in the crisis, and everyone was still trying to figure out, well, how do we handle this? But again, care was delayed, and the question is, would that have been different if it was another patient? And the patient was taken care of, and there was a question of whether or not this really was a heart attack or whether it was just COVID playing some tricks on us. But either way, the bottom line is that the standard of care, there was a deviation in the protocol that we had questions about, well, would this have happened if it was, like Asher mentioned, a politician or a very rich person?
This is the question, right? And so it's about access to equitable, consistent, quality care. And we in our work are, we seek universal health care. We want everyone to have quality, affordable, equitable care. But when these kinds of structural barriers exist for people, it is people of color, most typically, not exclusively, but 9 times out of 10, it is people of color who suffer harm. And I want to some people talk about, they blame people for not being compliant. They blame people for their lifestyle choices. I want to throw this question out to all of you, any of you who would like to answer it. There's a physician by the name of Kamara Jones, who's also a public health expert. And she talks about how up until about the 1950s, we had more of a public health orientation to health because we were still dealing with having access to water, and we were still dealing with rural, very, very concentrated poverty in rural areas. And then after that, we became, as a country, much more oriented toward health being about having a doctor and the medical model. And some would argue, right, that what we've got, this choice question, is defined by housing, it's defined by transportation, it's defined by education, by whether you can take time off to go to the doctor, if you even have a job. And those in public health are called social determinants of health. So what about that tendency in our systems to blame people for their situation and not to really get at these structural problems that are actually not, they contribute to health problems. They're not about healthcare. Any of you?
Well, this might sound a little peculiar, Frances. I never in my life thought I'd be in a position to disagree with Dr. Kamara Jones.
Okay.
I just want to put a different spin on this and say that I do not think, I think perhaps from the perspective of the public health profession or investment in public health, advances in public health, perhaps that is an accurate narrative.
Mm-hmm.
We look at the 1950s in the United States, we do not see a radical shift for communities of color. We do not see a radical shift for poor people in all of a sudden, you have less access to public health, or all of a sudden public health interventions are leaving your communities. What we see is quite the contrary. We see World War II veterans, Black and brown, coming home, trying to live out the American dream and still finding that they cannot get a job. They have no respect, that they are still being lynched, and tribal nations are languishing on reserves in our country. We do not see a shift, with the exception that we start to see in urban communities a coming together of a separate but equal does not exist in this country. And we're actually going to have an asset-based, community-centered mobilization in our faith institutions, in our cultural institutions. We are going to come together and organize. And much of that organization, so if I pivot to community health worker models and the origins of those models in this country, many of them, as a matter of fact, I can't think of one right now, as I think about the Young Lords, as I think about AIM, the American Indian Movement, as I think about the Black Panthers, and many others. You cannot separate their political activism and their anti-racist agenda with their public health agenda. All of them had survival programs. All of them acknowledge race and class and its impact on the survival of human beings. So I think we do need to consider our very powerful narratives in the United States and the ways in which we can actually hide what was really happening in this country. It's important now during this time to reflect upon movements of the past so that we don't quickly demonize movements, right? Movements of young people, movements that call people out into the street, movements that do destroy property, movements that make people like really concerned. We have to analyze those, and we can use history to do that. And we cannot look through the history of the United States and see any movement, whether it was the movement taxation without representation against the British, or any other movement that did not involve bodies coming out to the street, issues of class, issues of power. And so as we see communities of color talking about public health or social determinants of health, sometimes we separate those conversations. And I think we need to bring them together so we can move forward.
Thank you, Denise, for that, because I think that what we are talking about here is really is movements that dismantle the systems that exist and that make change that is inside out. And what we need is to take the really a role reversal and shift the narrative. I want to give you all an opportunity to talk about solutions, right? And there's short-term, mid-term, long-term solutions. To talk about solutions, because we have been talking about this for a long time, lots of conversations. Sometimes you think only people of color are having the conversations, but we got to get beyond talk, right? And so I have a question. So how do community health workers, doulas, recovery coaches, those people in positions that are close to the community, people who live in the community, who can maybe in the short and midterm actually be able to help people navigate? But then I'm also talking about the inside out and the regulatory needs that exist to change healthcare, to change the conditions that create these disparities. What are some of these fixes to inequity?
So Francis, I just wanted to say in relationship to what was just said that our very system of care is shaped by the inequalities that we're talking about. So sometimes we're relying on the system itself to help us to reform it. And it's almost like it gets in the way of itself, in doing that, because it's already based on principles that are set up to be unfair to our community. So I think part of the discussion is, confronting these terrible truths and confronting them about ourselves, confronting them about our institutions, confronting them about our policies, and also trying to think about these things in terms of extending more rights to other people, to people that have been marginalized, to people of color, and understanding how that plays out in the current system that we have. So I would say one of the things that I would suggest is that we call out the CEOs of Yale New Haven Hospital, of Hartford Healthcare. Those individuals should be presented and part of the solution as well, including our communities. I think that they are at the points of power, of influence, of status, that can help to try to regulate some of these changes that we're talking about. I think that obviously our voices are important in terms of swelling up towards these individuals and these entities that oversee our institutions. But I would say that we need to include these individuals as part of this very challenging discussion that we have to have, which also involves kind of an introspection about oneself, and not just looking at the system of care and the institutions and the policies, but it's also looking at yourselves and where you stand in the history of this country in terms of your privilege and your status.
We all have to do the individual work as well as the institutional and social work. I want to just do a little time check. We want to make sure we leave the time for our audience questions, and we're going to open it up for a couple of questions, and then maybe we can come back to this. And Julian and Denise, you can respond to this question as well. I'll remind everybody that you should have your questions in the chat room, and that Rose Ferraro from our staff is going to read off a question right now. Rose?
Absolutely. Hi, and thank you all for being here. Someone says that, Francis, you made a good point about people who have had these recent weeks occur as an awakening. And the question is, how can we address that gap between those just waking up and folks, people of color, who have lived with these oppressive conditions? So how do you address the gap between people who are just coming to this and people who have been dealing with this their whole lives?
Thank you, Rose. Who would like to take that question?
I think it's a matter of.
Yeah.
I'm sorry.
Please, Julian. It's that's massive.
It's such a loaded question, right? So, thank you for that question. I think that the way to bridge the gap is you really need to. We need to stop this tribalism mentality that we have in America, the have and have nots, the fact that we don't understand or listen to each other. I think there needs to be more knowing each other and working together. One example I have is, for instance, the military. Military, actually, believe it or not, is one of the few organizations that's pretty well integrated, and it does have its issues as any institution. But when you're in a combat situation, and doesn't matter who you're with, you're defending each other. So we need leadership in this country. We need leadership at the local, state, and federal levels to bring people together and help people understand each other and become more of a community. There's this separation between the individual and the community, and we need to understand that the inner city community is part of the overall fabric of America, and we need to understand that. we all are part of the American experience, and this individualism, us versus them mentality, is what's really hurting us. And one way to address it is each individually take responsibility and become your own leader and help others understand the issues that you are facing and that you see.
Lead from where you are. Denise?
Yeah, so it is a powerful question. I hope that I remember it well and can offer some reflection. I would say, if you are in these United States and you are looking at your TV or reading the news and you are shocked or surprised at anything that you see, anything at all that you see, as they say, you are not woke. But the concern is that the concern I would have is, what America are you living in? It would seem to me that you would be a person isolated if you cannot make meaningful connections, even in your own life, whether you're 18 or 68. You can look back over the timeline of your life, the life of your parents, the life of your grandparents, as that has been transferred to you, and see the reasons behind the symptoms. These are symptoms of larger issues. So for you, the journey would be to even be able to weep with mothers, to weep with communities, to sit in silence and consider that this is a multi-generational historical reality. The pain that it is calling up, the re-traumatization, is so profound right now. So if you are just waking up, that is your place to actually see if you can make meaningful emotional connection to the humanity and dignity of people that you are seeing, and you're kind of shocked at the responses, the anger, the horror, the frustration. If you are a white ally and you consider yourself to be woke, you have done the work, you've been involved in struggle, you are centering and deferring appropriately to the voices and the challenges and the preferences of communities of color in your sphere of influence, on your job or in your community, kind of wherever you are, then the push is for you to turn back to people who are from your culture and from your community, and really create a bridge of understanding and advocacy. Movements take power. Power takes numbers. It takes commitment. It takes consistency. It takes dollars, right? To make movement. And so if you're a white ally and you get it, then now is the time to dig in and find ways, whether you're on the street or not, find ways that you are going to nourish movements that are going to transform. If you're a person of color, and before we get off this, before we transition, I want to lift up our Asian American and Pacific Islander and Asian presenting communities who face stigma and violence, around what folks are calling this Chinese virus.
Right.
My heart just breaks in so many areas, for the 530 or so tribal nations who, as of May 15th, had not received any funding from the first two stimulus packages. There is a running list every 2 weeks that is released of what states and who gets their funding, and that these tribal nations had not received their funding from the first two stimulus packages to combat COVID. If you're a person of color living in this reality, first of all, I just want to lift up and encourage you to bring and call up and strengthen your resiliency and your healing, your self-care. Because your grandparents have been in this struggle, your elders have been in this struggle, your children will be in this struggle. And so we've got to sustain ourselves emotionally, mentally, psychologically, spiritually, physically. And so at whatever place you can give or work or serve, all of us can't go out on the street. Some of us have compromised immunities. Some of us are older or infirm or don't feel safe. But whatever you find to do, you can do that and nourish the next generation. Work with the next generation, support the next generation, talk to the next generation. We will be in this for some time, people. And
We
there's
certainly will.
to do.
The work is ahead. There's a quote from an article I was reading earlier today. The magnitude of this moment calls for us to push ahead with urgency, courage, and great intention to face our nation's racist history and reimagine and recreate a new future. And that is really, and we can all do something from our individual place, where from our particular corner, from our institutional place. There's a couple, I want to actually devote the rest of this time that we have, because we're actually nearing the end, to a couple more questions. And I think we haven't explored sufficiently the two things: the role of the community health worker, and to really like lift that up, because it's a pragmatic and immediate kind of thing that could really help a lot of people who are suffering right now. It's not systemic change all writ large. The other is Asher talked about everybody being part of the solution, the health systems being part, but how do doctors as individuals who took an oath to serve people, how do healthcare providers, not just doctors, also, what's the intention that you all can take? So let me start with the second question, then go to the first, and then I think we might just have, we may not even have, it's 12:55, we're running out of time, unfortunately. I knew this was gonna happen because this is actually a discussion that is just the first of many that are needed. But Julian, why don't you give it a quick stab, and then back to Denise, and then we'll do a close, okay?
Okay, so the question would be, how can doctors play a role? Based on what? Well, yeah. there was a side question also about, given the business practices of medicine, how can doctors overcome some of the obstacles that the business practice of medicine has in being able to practice the way we want to practice and serve the needs of the populations that we serve. Again, being involved in leadership. The problem with the business practices of medicine and the economic reality is that we're so tied up with the economics of keeping the offices open and the business of medicine that we don't have the ability to focus on leadership and working with the community. I think we need to work more with the community. We need to work with our community healthcare workers, and we need to work with the local institutions together better. We need to talk more. We need to work together. We all need to sit at the same table. It doesn't make sense that the community health centers are kind of like some silo in the community that we don't really know much about. And unless their patient comes to us, then we request their records and we have to wait through fax because they don't have an EMR that connects to us. It just doesn't make any sense. We need to be able to talk together. We need to be able to reach out and connect. So to make a long answer simple, we need to reach out and connect and talk to each other.
Yeah, which I think re-emphasizes the point you made, Denise. So recovery coaches, community health workers, that role, you got 30 seconds.
All right, so very quickly, Francis, in behavioral health, we have this concept of recovery coaches that was introduced about maybe 10, 12 years ago. And what we've seen is that this is a very powerful force in terms of mitigating the gap between treatment and the community itself, where you have individuals with lived experience who have been there, who have a narrative that they can apply and they could utilize when working with people who are transitioning out of treatment into the community. And what I think ultimately what that service does is to empower people that have for a long time felt very powerless. And I have some sense that this model can also be generalized or transferred over to the healthcare issues that we're talking about, in terms of having people who, like community healthcare workers, who I believe have a certain level of knowledge about the community itself, intimate knowledge that other people don't have. They apply that knowledge to be able to then negotiate and navigate through the system of care. And I think that looking at a model like that, where we include individuals from the community who either are trained and use their lived experience to empower people, is part of addressing the systematic issues. It's not the cure-all, I know that, but I think it can, it's a way of pushing the agenda forward.
So they can be organizers, right, Denise?
Yeah, so during this time, the National Association of Community Health Workers has been amplifying a couple really clear ways that public and private institutions can partner with and really invest in community. You all know that there are tens of billions of dollars that have been allocated over the last number of stimulus packages that we know Black and Brown people have had limited piecemeal access to. And so governance and accountability, I just want to acknowledge, is going to be paramount at the state level, right? We can't control everything that happens at the federal level, but we can demand this type of monitoring and accountability and allocation of resources that says we believe in equity and social justice. What that means for community health workers, number one, is that the state of Connecticut classify CHWs as critical frontline infrastructure workers. The U.S. Department of Homeland Security on March 19th identified CHWs as critical essential infrastructure workers, but most states did not adopt that language. Thus, many CHWs were laid off, they were fired, they were furloughed. Folks didn't know what to do with them because they didn't understand their role in reaching deep into community with education, with capacity building, with a care coordination, helping people to deal with social isolation, giving people a type of behaviors so that they can manage while they are social distancing. Classifying CHWs as critical infrastructure workers, giving them PPE, guidance, training, protocols. All of that is essential. Number two, we need
I'm
to
sorry.
invest in...
I'm sorry, Denise. We've run out of time, but here's what I want. Would you give your no, give your website to everybody right now?
I'll put it in
so
the
that
chat.
People can find out more about this. And I'm going to say that one of the ways that we can all act after today is actually to write to our legislators and say community health workers are essential frontline workers. And in Connecticut, we should reimburse their services through both commercial insurance and Medicaid. And I know a whole lot more to that, but I would encourage you to learn more from Denise's organization, the National Association of Community Health Workers. And I want to just close and thank you, the three of you. I wish we had 2.5 hours to keep this conversation going. I appreciate everyone who has been on. We had over 100 people on, and we are, in this together. We really are in this together for the long haul. We have to be, must be. So thank you to the speakers. Thank you for joining us, the audience. Please complete the very short evaluation survey that's going to pop up in about 30 seconds. And justice and peace. Without justice, there is no peace. Thank you. Till next time.
Thank you, Francis. Thank you all.
Francis, thank you, everyone.